Right, shall we get started then? Now we've all enjoyed the clap.
Yeah.
So for those of you that have not met me already, thank you all for joining us for our first Med Supply Drive UK webinar, PPE Evidence and Practice, and we're joined by Dr James Douglas and Councillor Neil McLean. Dr Douglas has been a GP in Fort William for 40 years and has 25 years of research interest in occupational health and aerosol generating procedures in industry. And Councillor Neil McLean is a PPE expert based in Lochaber, 20 years experience of PPE training in the geotechnical industry. Thank you very much to you both for joining us and leading this teaching session for us. I'll hand you all over now to Dr Douglas.
Okay, thank you very much, Gillian. And first of all, a big thank you from the team up here for inviting us to give this presentation. So I hope everybody can see the slide, but the slide has really just got the names of everybody, all of us in the room just now. So I'm going to start off with this presentation and then hand on to Neil. But the team, as you can see, is myself as a GP, Neil as the geotechnical expert, and Chris, who's the expert on photography. So one of the things that we've been doing, which you might or might not have been able to see, are a series of short videos that we've produced over the past week, where we've been using a smoke chamber in a converted freight container as a means of testing primarily the surgical mask, but also the FFP3 mask that we'll come on to talk about in a minute. So we're the team behind these slightly crazy videos that you might or might not have seen. And this is the team. So I've rather jokingly called it the Action Research Team for COVID-19, and it's based in Highland, Quarry. I'll explain that a little bit in a minute, but on the right there you'll see Neil. He's very much the rock star with the ideas, so a lot of the ideas that we've been talking about have come from Neil. I'm a standard NHS GP, and I'm standing there in my sandwich bar PPE, expected of me for seeing patients with COVID. And on the left is Chris Horsley, who very fortuitously has got locked down in the area. He's an expert on volcano photography and has been the camera person and the person who's done all the video editing for us, so a very important part of the team. And behind us you see our research lab, which is a shipping container. And this is Neil's yard, his company yard in Ballyhoolish. And behind Neil, Neil will talk a little bit himself about what he does and why he does it, but he's very much into community resilience. So the sort of freight lorry in the background there is Neil's idea to get food, so there's a secure source of food supply for his local community. So he's involved not just in PPE, but a lot of community work as well. This is Neil's area of technical expertise, so it's geotechnical, rope access type thing. But the bottom line for us tonight is that he spent a lot of his time drilling silica rock or silica-based rocks and many other sorts of rocks. And silicosis is obviously very damaging to health, so Neil's got a very in-depth understanding of PPE and industrial exposures. And this is one of Chris's beautiful photographs. His speciality, would you believe, is using rope access type techniques to climb down to get these sorts of pictures in volcanoes, which are absolutely staggering. He tells me that he's got many more, and he rattles off a series of volcanoes around the Western world that he's going to be going to, and we're looking forward to seeing those photographs. So about me, this is the first slide I want to talk to, and it's a bit odd, I'm sure, seeing we're talking about COVID-19 and putting up an old sepia photograph. But the reason for this is an interesting connection between the place we're sitting just now, this Ballyhoolish slate quarry, and a doctor from over 100 years ago. And that doctor's name was Dr. Lachlan Grant. He's the guy bending over the child, the baby, with a bowler hat. That was his PPE in the year 1900. And what he's doing is he's vaccinating that baby in 1900 against smallpox. Now, those of you from London will obviously be aware of the work done by Jenner back in 1796. And so, we only stopped doing, and smallpox is obviously a horrible fatal illness that's spread around by a virus. And we've been doing, or have done, smallpox vaccination. We did it for 200 years, so it took 200 years really from Jenner's discovery to get to the stage in the early 1990s where it was felt sufficient that we could actually stop doing smallpox vaccination, and it was completely eradicated from the world. So that just gives us a little bit of historical context for nasty viruses and how long it takes to completely get rid of them. Now the important point of why we find this guy Lachlan Grant so inspiring, this is a black and white photograph from the slate quarry that he worked in, where we're broadcasting from just now. He considered the relationships between work, health and housing, and at that time his thing was another communicable disease. It was all about TB, which was spreading around, and the fact that in the poor housing of the crofters and so on, the cattle were often infected with TB and spreading it around. And he had his own laboratory related to TB. And a very important point about Lachlan Grant was that he was employed by the quarry because this was pre-NHS days. So he stood up against his employer on health and safety issues, and on 2 occasions he was sacked by the quarry. And he was then subsequently reinstated. And the mechanism, the reason he was immunising a baby there was because part of the deal of being employed by the quarry was that he was able to provide health care to the people of in the local area who were employed at the quarry, and that was the kind of like mechanism. Now, that was all very well, but it was a bit of an unreliable mechanism for providing health care. And the government of the day, when we got to about 1912, just before the First World War, had a whole committee of inquiry that travelled around the Highlands and Islands of Scotland to try and find out what was the problem, why there was very poor healthcare and healthcare outcomes at that time. And it was all basically about the fact that the people were poor and they couldn't afford to pay the doctors to provide a service. So this Grant's big opportunity came in 1912, and he gave evidence to this committee, which is all meticulously documented in the report that you see in the centre there. And effectively, in the modern jargon, Grant spoke truth to power and said, look, there are big problems. But the key thing about Grant was that he not only said there are problems, he gave them the solutions. So they meticulously wrote down what his solutions were. And one of them was the concept of a national health service. So in the interwar years between the First World War and the Second World War, there was a medical service set up, paid for by the state, to provide general practitioners to the poor communities of the Highlands and Islands. And essentially that became the worked example pilot project for the National Health Service, which was founded in 1948. So there's a true, definite historical connection between this quarry, Dr. Lachlan Grant, and the founding of the National Health Service in 1948. So that's why I wanted to kind of just mention a slightly obscure point. The reason for going back to history is that I think all of us just now are quite conscious of the fact that we are living through history. It's not a war. It's been described in all sorts of war metaphors, though. But I think it's fairly likely that what's going on just now will be picked over by historians and so on and talked about in decades, if not centuries, to come. And I think it's an important point when you are going through a period in history, and I'm old enough to have gone through some other bits like Chernobyl and before coming down of the Berlin Wall, a number of big historical moments. And it's interesting when you get old enough to reflect back when people are telling that history back to you, what is truth and what is not truth. So a point certainly for the younger doctors and the students is just to kind of think about what's happening just now and think about what's said about it afterwards. Now this is my day job as a GP in Fort William. You see out of the window behind me is the mountain of Ben Nevis, which is Fort William, which is the highest mountain in the United Kingdom. And I've been a GP one way or another in the community for 40 years. I originally came to Fort William because of an occupational problem. At that stage, I came in 1979, and there was a problem in the developing oil industry, offshore oil industry at the time. In the rush to get oil out of the southern gas fields in the North Sea, there was a big problem with divers being killed at work. And the government of the day got very spooked up about this because there are lots of stories in the tabloid newspapers about these divers sacrificing their lives for this big economic boom. And the government's response at that time was to set up this diving school here on the west coast of Fort William. Now, in terms of PPE, which we're talking about just now, that's kind of like extreme PPE that you're seeing there. So on the left, that's a diver coming into a diving bell. On the water there, in the top left picture, there's a diving chamber. And so this was providing training for people going to depths of 200, 300 metres below the sea to do things like underwater welding and all sorts of underwater tasks. An interesting thing about this, if we think about that as an intervention, was that after that training and standards and all the rest of it which were introduced during that period, after about 20 years, it became safer to do underwater welding at 200 to 300 metres underneath the North Sea than welding in a car shop, in a garage in your local community. So it is possible, despite extreme danger and despite very difficult engineering things, to get PPE and get systems good enough to not have fatalities. So where we are just now in the NHS with fatalities should surely be solvable. It might take decades to do it, but it's certainly possible. And the next thing that happened in my personal career was that I got involved in the new industry of salmon farming. This is where the salmon fillets that you buy in Marks and Spencer's and all the supermarkets comes from in Scotland. And essentially, this was a new industry which started in around about the middle 80s, and they didn't have any medical input. And what came along in 1988 was that the big company, which was owned by Unilever at the time, had to deal with the control of substances hazardous to health regulations in 1988. But these are what you might hear referred to as the COSHH regulations. But they're really, really important because this was the first, certainly within Europe, it's European legislation. This set of legislation has probably done more to protect the health of people at work than any other single thing, certainly legislative terms since. And the reason why this legislation back in 1988 was so creative and so inspired, from my perspective anyway, is that they used the term substances hazardous to health. So therefore, it doesn't matter whether it's drilling rock and silica, as Neil's doing. It doesn't matter if you're working in the NHS and you're exposed to blood that's infected with HIV or hepatitis B or C or whatever else it is. It doesn't matter if you're dealing with an organophoshate pesticide chemical on a farm. There is a legal requirement of the employer to take measures to make sure that the employees are not poisoned by that. And this slide here with the guy leaning over the fish cage illustrates that point. So there's several processes in the COSHH regulations that happen at this point. The first was that the method of administering the pesticide into the fish cages was separated from the person. The person was covered in PPE, and then the person then had blood tests taken at regular intervals to make sure that despite the PPE, that the neurotoxin hadn't entered the blood. And the interesting thing about this slide, which was taken around about 1988, is that the PPE that you see the guy that they're wearing is the similar sort of PPE that you're probably seeing on slides from other countries in the world dealing with COVID. So the PPE and the technology around that PPE is not new, it's decades old. And the next thing that happened was that they were obviously growing the salmon in the cages in the sea, and then sending them out to market. So they had to develop methods of processing large amounts of salmon very quickly to send them down to markets in London and all over the world. And when they did that, they set up a factory, as you see here, for processing the fish and gutting the fish. And I noticed as a GP in the area that several of my patients who'd been unemployed and working at the factory started becoming asthmatic. And I then had to sort of follow through a research program over the next 5 years to kind of prove that hypothesis that this factory was causing asthma. So what it involved was, what happened was that when you force water at pressure through narrow orifices, you can generate aerosol. And respirable water aerosol is basically has to be less than 5 microns of size to get it down into your lungs. And these water aerosols in the breathing zone of the guy dressed in the blue overalls and hat were being inhaled. So I'm probably one of the few people, doctors in the UK, who's actually been around a factory with an aerosol meter, looking at where the aerosol is and going through an engineering process of trying to reduce that aerosol. And when we're talking about aerosol and what's inhalable, etc., if you'll notice in this picture towards the bottom, you'll see the big water droplets dropping to the floor, the ones that you can see, but the dangerous ones are around about where the guy's mouth is, and these are the ones where they're less than 5 microns. And that was written up in a paper in the Lancet if you're interested in the technical details of that. The other thing, the solution to that is up at the top of that picture in the blue bit where it says local exhaust ventilation. So instead of protecting the guy with PPE, you'll probably think, well, why has he not got a mask on? That's because we introduced the intervention of the stainless steel stacks above the water, above the gutting machine to extract the water aerosol before it got anywhere near the person. So any COSHH review actually tries to remove the dangerous thing from the person as the first response. And only after you can't do that do you introduce PPE. Now the reason I mention that is those of you who might be involved in designing hospitals for the future need to consider that. So instead of resorting to PPE and intensive care units just now, surely in the future hospitals will be designed with local extraction systems that suck away the dangerous aerosol from around the patient and around the members of staff. The next thing that got involved with was aluminium smelting. Now we're fortunate that we have a lot of water here in Fort William, or around about this area. And a very creative plan set up about 100 years ago to use the hydroelectric power that we have, the water that we have, to use to do aluminium smelting. Aluminium smelting is essentially about passing a large DC current through alumina, and then that in the cell room, which you see in the bottom right-hand grid there, and then make it into casting it, as you see in the truck on the left, into different alloys for different purposes. Now, the reason I mention this is another example where something very dangerous has now been made very safe. So the guy on the bottom right thing in the cell room, he's exposed, there's a potential risk during the setup phase of electrocution. There's a large electromagnetic field around about where he's standing, which is potentially dangerous to him. And he's dealing with hot molten metal that is exuding things like sulfur dioxide and a whole variety, hydrogen fluoride, a whole variety of sort of toxic gas cloud. However, it is possible to make that system safe, and also if you're pouring molten metal, that's obviously a very dangerous sort of thing. So despite all these very obvious in-your-face type industrial risks, it is possible, just like I was saying with the diving industry, to make these very industries very safe. And that's again a lesson for the NHS. The NHS needs to learn as we have deaths in healthcare workers. So you're probably thinking, well, what on earth has all this got to do with COVID-19 today? Well, it really boils down to the Public Health England statements within the United Kingdom, and therefore following on to the other 4 nations, or the other 3 nations, is the personal protective equipment policy for COVID-19. Now, the difficulty that I have with the Public Health England statement on PPE is that it's clearly been written by public health epidemiologists who've just really done an evidence-based review. And I know for a fact, because I've been speaking to some senior members of the occupational health community in the UK, that they didn't have occupational medicine knowledge or experience in their evidence-based review, which I find absolutely astounding. And as the net result of this, and I know that the occupational health community has got their heads in the hands at the moment at a very senior level about what's going on and the PPE that they've gone and backed. What they've actually done with this evidence-based review, based on a really pretty poor, weak evidence base, is they've backed surgical masks as being safe out with so-called aerosol-generating areas. And effectively, they're digging themselves a deeper and deeper hole, which they now can't get themselves out of. And the only way that I can foresee themselves getting out of this hole and not giving PPE 3 type masks to everybody is using industry. And effectively, I think we've now got a situation where they're matching the PPE policy to the supply and not applying a basic risk analysis grid. And I'll just show you what a risk analysis grid looks like. Now this is one which is these sorts of things used widely in industry. On the left-hand axis you'll see likelihood, so something very likely or something very unlikely. And on the top you've got either impact or consequence, you can call it either, from negligible up to severe. And we know from when COVID-19 first started in China, the early death was obviously the poor doctor that died, the whistleblowing doctor. So we know right from get-go that COVID was a potential cause of death in health workers. And then as the thing accelerated and has been in Italy and Spain, through all our networks, we've known that there have been healthcare workers who died in these countries. So it's been clear right from the early stages of COVID-19 that death is a consequence. So if you've got a high consequence or severe consequence, death of a healthcare worker in the red arrow, the red bit on the right, and it's possible, doesn't happen to everybody, but certainly it is absolutely possible, all your actions end up in the red area. They don't end up in green, they don't end up in moderate. So if the surgical face mask that we can consider in a minute was okay, you can maybe do something in the moderate area. But as the consequence is death, you shouldn't even be thinking about that. You've got to go straight to the highest level of protection. Now, the industrial analogy for all this is asbestos work. Now, shipyard workers and other industries who work with asbestos in shipyards inhale the asbestos fibres, and then some of them, not all of them, get mesothelioma, a horrible cancer of the pleural membrane 30 years later. Now, I'm just thinking about the people in my practice that I've had with mesothelioma, and I can remember just 8 names off the top of my head, so we've had quite a bit of a problem with it. And I'm also aware of 2 doctors that have died of mesothelioma, and I'll tell you about those in a second. But essentially, it's all about a disease expression related to an environmental cause, in other words, inhaling an asbestos fibre. Now, if we wind the clock now that we know that asbestos can kill you, and we wind the clock forward in an industrial sense, there's now a whole industry based upon clearing asbestos where you've got to get rid of it for some reason. And all the people in that industry are now super protected, as though they're going to do a moonwalk in PPE to make sure that they don't get asbestos into their lungs and later die. That they don't die of mesothelioma. And just as a little interesting side bit of history, the 2 doctors that unfortunately they're sadly dead, but they're people who are about my age. They were junior doctors in the Western Infirmary in Glasgow. The Western Infirmary in the basement had pipes that were lagged with asbestos, and in the days before digitised x-rays and old-fashioned x-ray plates, the old overspill x-rays were left in the basement of the hospital. So if you were on the professor's ward round, it was your duty to kind of go down into the basement amongst the asbestos pipes and so on to find the x-rays. And little did these poor people think, as junior doctors, that their devotion to the professorial unit of medicine and getting the x-rays to the ward round would cost them their lives 30 years later, but it certainly did. So some unexpected things can occur. Now, we are where we are at the moment with wet surgical masks. Now this is with the Public Health England information and policies, etc., and diagrams. They're still advising, and I checked the advice this morning from our local health board, and it still is wet surgical mask type 2R for everything, except known aerosol generating procedures. An important bit about understanding the PPE is what is it designed to do? Well, it certainly wasn't designed to protect you from inhaled droplets. It's designed to protect the patient from the doctor, and it's designed to detect liquid splashes from the patient. And if you want to understand a wet surgical mask, then cut it up and have a look through and see the fibres, and you'll see the design of it. But the main point is that you're breathing through the open sides of it, and there's no seal. And certainly the smoke test things that we ran in the freight container showed that there was that with the tracer smoke collecting in the breathing tube that I was wearing in the smoke chamber, got completely covered in the smoke, the trace of smoke that we were using. And on Sunday we tried another run of that test with a visor to see, in the wistful hope that perhaps a visor might reduce that smoke ingress and smoke contamination, and unfortunately it didn't. So there's no added benefit from a respiratory protector from our smoke test of wearing a visor. It doesn't protect your lungs at all. The next question is, well, what is a respirable particle? So if you're going back to thinking about the Health Protection England guidelines, well, cigarette smoke is clearly a respirable particle. A vape cloud is clearly a respirable particle. As I described, a long, thin asbestos fibre is respirable. And a salbutamol inhaler. Salbutamol inhalers are designed to give you an aerosol of the right size to get to the bronchi in your lungs and give you bronchodilation. And one of the things I was going to suggest to you today was get hold of a salbutamol inhaler and open it up and hold it and shake it, and then open it up and then squirt it out, and just see how far, what the cloud looks like when you press the top of the inhaler, just holding it in your hand and squirting it in front of you, obviously not inhaling it. You can see that probably is a rough approximation, a model of a cough cloud. So the next bit of evidence to question the Health Protection England document and Health Protection Scotland document came from the Massachusetts Institute of Technology in JAMA, the Journal of the American Medical Association, on the 23rd of March 2020. That reference is given in our references at the end, but that models what a cough cloud looks like with some clever laser type photography, and you can see this cough cloud with a whole variety of particle sizes. The other bit of historical evidence that this Health Protection England study conveniently forgot to read was a study on norovirus particles in healthcare facilities done in Quebec in 2015. Now, you can obviously, when you look at our smoke tests, if you have a look at them on the video, you can obviously look at the smoke tests and think, well, how on earth does that represent anything to do with working in an intensive care unit or a general ward? Well, the conceptual model that we've used is that our smoke test, where we're subjecting ourselves to a 5-minute exposure, is effectively a model for an 8-hour shift exposure of respirable particles. So in other words, okay, it's a big dose, one that we can see and pick up, and I'm only in there for 5 minutes when I'm doing the test, but effectively, in occupational hygiene science, that's a perfectly acceptable method of doing what's called a time-weighted exposure for a working shift, an 8-hour shift. So what we're seeing in the smoke test videos is, okay, it's only 5 minutes, but at a big dose, but it models what you're probably respiring over an 8-hour shift in an intensive care unit or a general ward. Now, I think it's important to understand, again, when you're kind of trying to understand the most basics of this, is what is the size of particles and where do they go and where do they end up? And obviously on the left-hand side, we've got a model of the lungs, we've got bronchi going down to bronchioles, down to alveolar level. And our first line of defence is obviously a big water particle getting blocked in the nasal hairs and the nasal lining, then maybe getting stuck on the tonsils or the adenoids, or then going further down the respiratory tree to bronchi, bronchio, alveoli, or pleura. And a good way of thinking about that is the difference between inhaled corticosteroids inhalers for asthma. So the one that most people use will be a beclomethasone type one, like Clenil or Becotide or one of those brands, and they're designed to get to the bronchi level, but the better ones are the same drug. There's one called Q-Bar, where it's got an ultra-fine particle spray, and it's designed to get down to the alveolar level, much lower down the tree, and is a much more powerful drug. Therefore, you need less of that particular drug to get the same dose response as you do with a Clenil inhaler. So particle size and where it goes to in the lungs is well known. There's a whole established science about inhalers and how to get the right drug and the right particle size to the right place at the right time. So again, The people that did this evidence review, I don't think know anything about inhaled particles from what they've said. And obviously, if you are inhaling an asbestos fibre, a long, thin fibre, that can wind its way down to the base of your lungs and get through to alveoli and then over to the pleural level to cause the mesothelioma. Now this is a picture of me, and I'm wearing the PPE that is currently being issued by the Scottish Government to general practices for GPs to be seeing potential COVID patients in the community COVID assessment hubs. And the main point to take in is when you see the surgical mask that I've just been talking about, there's an arrow where I'm breathing in. So you're breathing in through there. I'm wearing the standard issue disposable one-off specs. They're balancing on the top of my glasses, and the difficulty with them is that potentially you're going to just end up touching your face, trying to push them back onto your face, and particularly if your hands have then been touching something, a surface contaminated with COVID, all you're going to do with that very poor system is touch your face. And as you see, my hand is resting on the plastic apron, and it's resting on sort of work-type trousers, and obviously now I'm wearing scrubs. But for the purpose of this demonstration, what they say in all their pictures is that you just wear your ordinary work clothes. So obviously you're taking that home with you. Now, referring back to the Health and Safety Executive, if you're interested in occupational health and all this topic, there's a wealth of information on the Health and Safety Executive government website, and I would certainly recommend you have a look at it. There's various drop-downs and ways of navigating the website. You can look by topics such as the control of substances, hazardous health regulations, or you can go by industry such as construction or diving or whatever the industry is. And just out of interest, when I went into the COSHH section the other day, I'm delighted in the fact, I didn't know this existed until earlier this week, there's actually a COSHH risk assessment for a sandwich maker. So I'm really rather pleased that Health Protection England have been consulting their sandwich maker COSHH assessment to determine the PPE for me assessing patients with COVID-19. This, of course, is an approximation of what I should be wearing. And the first question of any industrial risk assessment is that you've really got to make your own risk assessment, because the risk assessment is a dynamic process that changes. So in the healthcare setting, you obviously, are you going to be taking throat swabs? Well, if you're going to be taking throat and nasal swabs to make a diagnosis of COVID-19, it's a real sporting chance the patient is going to cough all over you. Is the patient, as one of the prime symptoms of COVID is cough, that's where all the triage thing's saying, so it's a racing certainty that anybody in a COVID assessment ward, before they're anaesthetised on a ventilator, will be coughing and spluttering. The next thing is, what can you not do, and what's not a good idea? What can you stop doing to put yourself at risk? There's a peak flow meter on the table there to remind me, but what you shouldn't be doing is doing peak flow measurements, because you're asking the patient at that point to do a forced expiration through a peak flow meter. That's going to break up the particle size and guarantee to produce a respirable aerosol as it comes whistling out the other end of the peak flow meter. So don't do peak flows in a ward or in a closed environment. Ask the patient to record their peak flow before they come to see you if you're in a primary care setting. The PPE that I'm wearing at the top are reusable goggles. So these are just ordinary industrial goggles. You can buy cheap ones for £5, rather better ones that look a bit like ski goggles that cost £15. And one of those would do each doctor or nurse or healthcare worker for the whole of the epidemic, just washing it properly and looking after it. I'm wearing a reusable FP3 half mask. The cost of those is £25. They're much more comfortable and easier to wear than the disposable ones, and they, according to the manufacturers, 3M, will last you for the whole of a flu epidemic. In contrast, the NHS, if you're working in an aerosol generating area such as an intensive care unit, is asking people to use single-use FP3 masks. Everybody's running out of those. They cost £5 a pop, and so if you just do the sums, it's quite simple, isn't it? they would actually, in one week, be much cheaper issuing everybody with the proper thing right away at the start and asking people to look after them. Now, there's been a big supply, there's been a lot of anxiety in primary care, in general practice and in care homes, etc., about being expected to work with bare arms when you're seeing people with COVID-19. That's certainly what we've been expected to do. The solution to that, if you haven't got the surgical gowns that go over the front, is to use simple builders type suits. You can use a decorator's type suit that you probably won't be able to find them in B&Q at the moment, but a simple decorating suit that you would use to decorating your room at home to keep the paint off is certainly going to be a little bit better than bare arms, a little bit better than getting it directly onto your scrubs. You can obviously take it off and chuck that away. The better grades of suit, the chemical type ones vary between £5 and £8, and these ones that have got a chemical certification to not allow the ingress of chemicals. So, in this outfit that I'm wearing is kind of like the mid-range one, so in other words it's the decorating overall with the sandwich bar apron and hood. And hair cover is important. You don't really want to have a COVID shower of cough shampoo, so I think protecting your hair is important. If you can't get something to cover your hair, then I would suggest something like throwaway shower caps. The other thing about donning and doffing is you're much better getting a large size suit for doffing. You've got to be able to wriggle out of it afterwards. And in the video that I looked at on our own health board website, which I think came from the UCH in London or somewhere in London, public health thing is saying you don't need to do double gloving for doffing. Well, I think that's just absolute nonsense. I don't think you should go near this without either putting 2 gloves on at the start or changing your gloves halfway through. And the main thing from any industrial system, as Neil will probably come on to talk about in a minute, is that if you have a buddy system for doing PPE checks, you increase your margin of safety hugely many times. So buddy systems are really important. The other bit that I would advise you to do, is very important to understand any PPE that you're using. And this is a PPE 3 disposable mask, and what you see is that we've cut it up to demonstrate what the layers look like. There are 3 layers, and the white stuff is what you're taking your inspiratory breath through. The bottom grey layer is the seal that works on your face, and the top layer is the exhalation valve. Unless the mask that you've been given has got an exhalation valve, then it's basically useless, and it'll give you as good protection as the surgical mask. So you've got to breathe air into the filter and out through the valve. Now, the whole question of fit testing is quite an important one. Health boards are really pretty obsessed with fit testing because it's part of the statutory training required for COSHH regulations. So fit testing involves getting hood put over your head, wearing the FFP3 mask, putting your head in various positions and saying whether you can taste a bitter taste on one occasion. So however, all that's doing is telling you that the mask is fit and tight on that particular occasion, but in fact, fit testing should be a dynamic process that you have daily checks with the buddy system. You should certainly begin with reading the instructions in the box, so whatever the box is that the PPE came out of, there will be screeds of instructions and diagrams. Look at the instructions. The other thing is to practice the donning bit and getting the handhold correctly. Now, Neil and Chris and I have got a video coming out maybe at the end of the week where we're trying to demonstrate the correct holding position and putting on a mask to you. The other thing about the daily testing with a buddy is making sure you've got the nose clip properly on, and also getting the correct tension on your face with using the neck straps and the head straps on each side to make a comfortable seal. And the emphasis here is on comfortable seal, and it's got to be symmetrical on your face. I've heard some horror stories locally in our local hospital that people have been advised to tighten the straps until they feel pain. Now that absolutely horrifies me, because all you're going to do that is you're going to, if you over-tighten it to the stage of getting pain, you're going to squash the capillaries on your face, and then you certainly will end up getting facial skin problems because of that direct trauma. When you're talking on a ward, obviously all these respiratory systems cover your mouth, so your chin seal will loosen with talking, and so you've got to reconsider that during your shift. Unfortunately, you've got to be clean shaven, and it's important to test before you go out onto the ward today's seal with your buggy. Now, what happens if your face does start breaking down? Well, again, in the video that's coming out at the, just shortly, will prove to you that you mustn't use creams on your face at donning or around the seal to try and improve the seal. The reason for that being is that creams, residue left of the cream, will be a major risk for you in docking, because if a COVID-19 particle has landed on your face exterior to the mask and is stuck to the cream, then that COVID-19 particle is then in a very preferential position for getting into your eyes as you try and wash it off. So please don't use cream during your donning process. The other thing when you're taking the mask off is to inspect your buddy's face to look for tension marks. In other words, have they been getting it too tight? I would encourage the use of hydrating creams on your face, just the obvious things such as Diprobase or 50/50 or Latum E45, that sort of thing, but do it before you go to sleep, not before you go on shift. Now, if your face does start breaking down, I don't think you should be on duty until it's healed, because obviously that's going to be a port of infection risk. And what you should be doing, if you are running into these problems, is to ask occupational health or dermatology for help. One of the questions that you need to be thinking about is, could you have become sensitised to the ingredients of all the washes, ointments and creams, etc. And please don't use steroids on your face without a consultation with somebody, your GP or dermatologist or somebody, and be given a proper prescription. So don't just nick steroid out of the ward supply and apply it to your face. You'll cause big problems if you attempt to do that. Now, the other question is really the debate between reusable and half mask type things. I've already said that the cost of the moulded half mask type thing is £25 versus a one-off cost of £5 per reusable one. So it would make economic sense for the health service to properly use the reusable sort. If it is the reusable sort, then I feel that it really needs to be a personal issue. Therefore, that it's your responsibility for the care and cleaning of the thing. The control of infection issues are completely doable and completely possible if people have personal responsibility for that sort of system and more training. I know the control of infection people will throw up their hands at this thought, but if they haven't really got any better ideas about how to protect the staff. The other thing is to use your local industry as a supply or potential supply of the reusable half masks, because all these industries have got locked up stores of this sort of stuff. And they are the experts and could run the sessions, the industrial training sessions, if they're only given the opportunity on how to use the masks. So, just the final word, just to take us right the way back to Lachlan Grant. He spoke truth to power, and I think that's what we've got to do just now. And his results did come good. We eventually had the National Health Service in 1948. And I believe the solution to the NHS COVID-19 personal protective equipment problem is industry and asking for industry's help. So at that point, the next couple of slides are the references, etc., but I'll leave them and pass over to Neil.
Hi. So, what I'd like to cover is basically how I got involved in this and how sort of industry and so how industry and the sort of geotechnical civil engineering world collided. So when this first kicked off, we first started up a community group at Ballywoolish, because we soon figured out that it would be far better to have a strong community going into this. So we set up a group that looked for weaknesses in the community and then tried to tie them up with the strengths within the community. I was absolutely horrified to find out that one of the weaknesses in our community was the PPE that was in the frontline staff. So then set about tying up that with some of the strengths. It was an obvious conclusion for myself and the industry that I'm in to look to industry for the PPE. For example, I went to a local hospital on the first day of my missions on PPE and found that they had 10 masks and 3 face shields, whereas in this quarry here, just happened to, we had in our stores 380 FFP3 masks, so there was an obvious difference. So we were very quickly able to resupply the hospital when they'd been let down time and time again by their suppliers. I then met Jim through going to visit the community nurses, who said you need to come downstairs and meet a guy downstairs who's been working hard on PPE as well. So then we've sort of moved on from there. I think we had quite good success in Lochaber in that we managed to secure PPE. We still know where there's PPE in stock. We have quite a high level of PPE on the front line, the sort of PPE I would expect to see in a work site. Now, FFP3 masks are the bare minimum that we would use on a work site, the absolute bare minimum. FFP2s wouldn't entertain them. Surgical masks, you would get laughed off the site if you turned up a surgical mask. There's been real hard lessons learned in the industry that have involved probably thousands of people dying to get to the stage where we are now with the knowledge that we have now, and that should not be wasted by the NHS. They need to look very closely at it. We touched on a few points, the systems that we use, so buddy-buddy systems, checking PPE, having a stock of PPE, all these things that are just normal day-to-day in industry. So as part of my work in the last few days, I was going around some of the industries to see what other PPE we could get, and I was absolutely horrified to speak to the gentleman who was the chairman of the British Asbestos Association and find out that I was the first person to phone him. Now, he doesn't only have PPE within his cascade and echelon of companies, he has expertise. Now, asbestos used to, as mentioned before, it used to be a hazard and now it's controlled. So the hazard hasn't went away, but the control measures have lifted up to meet the hazard. And it's going to be the same with COVID one day, because it's not going to be sustainable to lose hundreds of medical staff to it. Now, the type of investments that we're looking at, one of the things that sticks out in my head is that to bring somebody up to a consultant level when they're in a position where they're actually looking after people must cost hundreds of thousands of pounds. And a piece of kit like this, it costs £200. Now, these could easily be issued out. There is short supply of these at the moment, but the money, and they'll pay for themselves masks, and everyone would then be completely comfortable with how to use them. So it's this type of mask is the type of mask that the military issue to people. Now, they're obviously expert at logistics, and they don't want to have to keep resupplying because it's really difficult to do it in the situation they're working in. So their system of issuing a respirator to each person and then they look after that and they train in that and they have it, that's got to be the way forward to protect the NHS staff. Now, one of the things that we are wary of on site is fit testing. Now, fit testing is a box ticking exercise for a later legal battle to say that you have provided adequate PPE to that person. Now, they only test you on that one day. Now, that doesn't mean the next day something hasn't changed. And that's why the buddy-buddy system is really important. And it's why getting to know your equipment is really important. Why trusting your equipment is really important. Now, 75% of people that use PPE for the first time will use it incorrectly. So that is a huge reason why you need to get to know these systems and be really, really happy to completely interrogate and, as Jim mentioned, to cut the stuff open and see what it's made of. And I think that's a big takeaway point from this, is to really, this is now in your world. This is you need to now accept that as being part of your world. We in industry have done that. We've embraced it. The guys that I use and girls that go up cliffs drilling holes in rock, this is just normal day to day for them. If they've seen people over tightening their masks, they would know it was wrong. They would know the seal wasn't working. So we really can't stress enough that industry would be there to help and look at the lessons learned. I mean, they've been painfully learned, so that can't be ignored. And I think people need to be in a position where they call things out when they see them and challenge and talk truth to power and really correct people when they're wrong and look at the evidence. So the evidence is strong, the regulations are strong, and we really need to be in a position where the medical community feel empowered enough to stand up to the managers and the politicians and say, no, this is not correct, and this is what we believe. So I mean, that's really what's happened in industry, and it's accepted now. And I think that's really something that once you become, that becomes part of your life, and that accepted way of being. I mean, I'm sure that one day in history, in medicine, they never used to sterilise things. So that lesson was learned, and now it's a normal part of life. So I think that's going to have to be the way forward. And strongly, I would have to say that mechanical and design solutions aren't the way forward. PPE should be the last resort. PPE's got a habit of failing. PPE's got a habit of being worn incorrectly. So if you design the solutions in to take the onus off the PPE, even better. But you need to learn how to trust it as well. So the situation you're in at the moment, the PPE is your first and sometimes only line of defence, because the design solutions aren't there. And it's a real shame that they're not there. But hopefully, I hope that one day we'll see hospitals that are capable of providing the same protection that's provided to people in industrial settings. So I'll probably better hand it back over, because we've got 7 minutes. So I don't know if Gillian wants to round things up or maybe go through some questions.
Great, thank you both very much for your time and for sharing your knowledge and expertise with us. If anybody has a question, would you be so kind as to type it into the chat box, and I'll share the questions for Dr. Douglas and Councillor McLean. So we have a first question from Eleanor Robertson. Would you just advise us to buy a full face mask?
For me, well, I can cover that. I've been trying to buy as many full face masks as I can. There is some still available on eBay, but somebody did order one that I know a week ago, and they've still not received it. But some of the ones we've ordered, we have received. We've managed to find some down south, which we're planning to go down and buy. But yes, if you can get your hands on a full face mask, yes, definitely get one, and learn how to use it. The manufacturer's instructions are on them, they're not rocket science. So yes, if you can get hands on one, definitely get one. Maybe worth noting that some of your family may use them in their day-to-day work as well, so reach out to them and tell them that you need them.
Yeah, maybe I could just say something at this point about taking in, with the hierarchy of particularly hospital systems and so on, and taking in your own equipment and being challenged by infection control or the manager or something saying you can't wear that equipment in here because we've not bought it. I did look at the BMA website this afternoon to see what the current advice on that is, and so I would have a look at the BMA website to see what they're exactly saying. But they're basically saying if you do feel unsafe and you want to use your own stuff, effectively what I took from what it said was that if you feel unsafe, use your own stuff, and if you do get challenged, they'll support you. And the other thing is ask the patient to, if there's a manager or an infection control unit person, ask them for the COSHH assessment of the task you're just about to do. Say, thanks very much, can I see your COSHH assessment, please? They won't have one, but that's the thing to fire back at somebody who's being stroppy at you and saying you can't do this, you can't say that. Or if it gets really, really nasty, then sort of say, assume that you'll be legally accountable with your duty of care in the fatal accident inquiry if this does go wrong, because you would be held accountable and you could be guilty of corporate manslaughter.
So that's a huge one. If you look at some of the other investigations that have been carried out, people really need to look at them. So the things in history, Hillsborough disaster, the Piper Alpha disaster, Hatfield train crash, if you look at these things in history, you will see that that is being repeated at the moment. We've only got 4 minutes left to run, so...
Yeah, thank you. We've got a few more questions. This one's for Dr. Douglas, please. It's from Lisa Barnard. She asks, could you talk more about coughing as an aerosol generating procedure?
well, coughing, if you look at the main reference for that is the Massachusetts Institute of Technology paper. If you get it, there's a video in that paper of a cough cloud which shows a sort of variable size of particle. What I would say about all this is just at a common sense level. If we're being asked to socially distance, to be 2 metres or 3 metres or whatever it is apart while going for a walk in the park, where is the logic that says that it's absolutely acceptable to have a patient coughing over you and within 1 metre, which is effectively what you're doing? Or if you're asking a patient to do, if you're listening to their chest as a doctor or a nurse and you're asking them to breathe in and breathe out, whereas somebody in a palliative care situation in a nursing home, and their lungs are absolutely full of horrible secretions and they're coughing their last before they die, and a member of the care staff is looking after them, then I just cannot accept the position of Public Health Scotland, Public Health England, that that's not a dangerous procedure for the care staff. And if you're wearing a surgical mask, you're just going to be breathing the expired air from round about the patient into your lungs. So it's all a question, the coughing thing is all about, and the risk to the healthcare professional, I think, is all about the viral load and also the size of the particle. But also, it presupposes that there's the same response in every individual.
You've got a minute left.
Yeah, so I just go back to the example of asbestos. So everybody, for all the people that inhaled asbestos, you've got a complete range of disease, from pleural plaques to pulmonary fibrosis to mesothelioma. And it's the same with inhaled COVID. So some people can inhale it and then they're fine. Other people will be dead within a matter of 2 or 3 weeks. Because every individual is not the same. So I think you always have to assume and have your safety according to the worst possible outcome, that somebody whose biology can't deal with COVID will die from it. So that's why you have to always assume that worst category, because we've got no means of predicting in advance what the risk factors are.
So, I think we've only got a minute left. Somebody's asked a question there about how to stand up to managers, but I think the best thing to do there is figure out what you're more frightened of, manager or COVID, and act accordingly. Industry sees quite a lot of injuries that are preventable, and it goes to a blame stage, and they need to be very aware of that. We've only got a minute left, so I dare say we'll be better. I think all these other questions, if you just fire them in, we can answer them over the emails and get them out to you as well.
Yeah, absolutely. Thank you all very much indeed for joining us, and take care. Bye bye for now.
Cheers, folks. Bye bye.
Bye.
Thank you.
Thanks so much. That was amazing.